very good evening to all my colleagues from across the country in India, and a very good morning to those of you who are joining from America. I am Dr. Gurpreet Singh Wanda, your host and moderator for the scientific deliberations that we are going to have on COVID-19 cardiovascular manifestations today. I work in Dayanand Medical College and Hospital in a tertiary care cardiac center in the city of Ludhiana in the state of Punjab. And we will be discussing, we have three experts from America, from New York and Pittsburgh, who will be making presentations. And then we will be having a 15 minutes question and answer session when we can ask them about their experiences, since they are dealing with many more patients of COVID-19 than thankfully what we have had to deal over here in India till now. Friends, you will all agree we are passing through a very difficult, very challenging, and very testing time in our lifetime when we are having to deal with this pandemic of COVID-19. It is a disease which is caused by a coronavirus. No longer are we specialists or super specialists in any particular disease. And this disease is not in the domain of just the infectious disease specialists or the intensivists. Actually, specialists from all fields are now having to deal with this disease for the large number of patients that are presenting, and also because a few of these patients go on to develop multi-organ dysfunction syndrome and systemic inflammatory response syndrome, and the microangiopathy that occurs affects the liver, kidneys, heart, and thus afflicts all organs. And so for the first time in medicine, actually, the medical fraternity, not only the medical fraternity, actually the media, the administration, everyone is collected together to fight this pandemic. In the last 3 odd months that we have been dealing with this pandemic, we have almost every day we have been having new manifestations, new modes of presentations, and we have been testing various forms of therapy. The New England Journal of Medicine, the Lancet, JAMA, and most Indian journals have started publishing online. We are no longer waiting for peer review, and whatever knowledge is there, we are keen on sharing with each other. And keeping this in mind, we have invited 3 experts, 2 from New York and 1 from Pittsburgh. One of them is an infectious disease specialist and 2 are cardiologists. And we will dwell upon these manifestations, presentation, and various therapeutic options that we have on COVID-19. We in India till now have not had that many patients, and it would be the right time today on the 18th of April for all of us to learn from these experts as to how best we can manage our patients, since these patients come with varied presentations. We can only become strong and effective if we all pool in our resources, and so we work together as a team. We share our knowledge and expertise and experiences, because no one has had such an experience in a lifetime. We are having to deal with a large number of patients. In fact, unprecedented things are being talked of, like a single ventilator being used on multiple patients. And so today, although we are focusing largely on the cardiac manifestations and what the current perspective is, I will just in the next 3 or 4 minutes present a couple of slides and would not like to be between you and these experts. And I thought I'll just take you through. It appears as if it's been a long time that our life has changed. But actually, if you look at it, it was only on 31st of December that China first reported to the World Health Organization that such a disease is happening and is presenting as a viral pneumonia to patients. Although they say that on 12th of December, they started seeing these patients in Wuhan, in the province of Hubei. Couple of days later, the disease started presenting in Thailand, and by 21st of January, the first case was reported from United States of America. The World Health Organization met on the 20th of January, and at that time, they did not feel that it was an emergency. But within 10 days, the numbers were increasing, and they quickly realized by 30th of January, and they declared it as a global health emergency. And within a couple of weeks, by 11th of December, this was declared as a global pandemic, that it truly is today. I might remind you here, the last pandemic we had was the H1N1 flu pandemic in 2009, which did not cause the kind of devastation that we are seeing today. As we sit here today on the 18th of April, we have had 2.2 million people all across the world. And mind you, this is the reported cases. There are many more asymptomatic patients, mildly symptomatic patients who do not get reported. And 150,000 people have lost their lives, unfortunately, due to this COVID-19 coronavirus caused pandemic. If you look at just United States of America, 700,000 people have been affected, and 37,000 people have lost their lives. In India, although we do realize we have under-reporting, under-testing, but we still have 14,000 people who are affected, and about 5,000 of them have lost their lives. So the pandemic has virtually been growing every day, and the doubling time has been reducing over the last couple of days. Coronaviruses are not new to us. They were discovered in the 60s, and they're known to cause a common cold like flu. Actually, this is not a common cold. It's an uncommon kind of a cold in which fever and intractable cough are much major modes of presentation than rhinorrhea that we see with flu. There are 7 known strains, alpha, beta, and we are all very familiar with the SARS-CoV-1, which affected about 10,000 lives lost in 2002-03 in that epidemic. It started again from China, from Guangdong, and went on to spread to a couple of countries. MERS started from Middle East, and although the mortality was much higher, but lesser number of people were affected. We know coronaviruses are harbored in bats, in camels, in penguins. And once there is an animal to human transmission, that is what causes the problem. And then the human to human chain sets in and then causes this devastation. Just one slide I thought I'll share with you on the disease spectrum. It's now known that 81% of the patients are mild. We know some of them are asymptomatic. About 14% of them have more of hypoxia, they are dyspneic, and more than 50% of the lungs get involved. They need hospitalization. And about 5% of them are critically affected. They go into shock. They have ARDS, multi-organ failure. The mortality is believed to be 2.3% amongst individuals who are hospitalized, although the epidemiologists feel that the mortality might be somewhere between 0.5 to 1.5% because we are not taking a large percentage of patients into account who are afflicted but not reporting. The high-risk populations are elderly, obese, males, and those who have comorbidities. We all know this too will pass, and the medical fraternity, with support from all of us and from each other, we will be able to handle this, and the life will go back to normal, what we used to have earlier. Let's have the 3 presentations now, friends, and then we will go on to have the question answer session. The first speaker is Professor David Hirschwerk. Professor Hirschwerk is actually presently the Vice Chair, Department of Medicine at the prestigious North Shore University Hospital, Long Island Jewish Medical Center in US. He's an infectious disease specialist with special interest in infections in the immune-compromised individuals. He was trained in the prestigious Mount Sinai School of Medicine in Manhattan, where he was a chief resident, and we are all very keen to listen to him and then share some of the questions with Dr. David Hirschberg. Over to Dr. Hirschberg.
Hello, and thank you for having me as part of this panel. I am part of the Northwell Health System, where we at this point have taken care of several thousand patients who have been infected with COVID-19. We are a health system of over 20 hospitals in the New York metropolitan area, consisting of 2 main tertiary care centers, and that is where the majority of our hospitalized patients have been cared for. But within the region, we have several other hospitals and a very large ambulatory practice. So what I will speak about is some background information on coronavirus, and we'll also share some of the experiences of our health system at this point and some lessons learned, and then we'll transition from there. So I will just say that coronavirus, as you have heard, has been recognized now for several decades, and including what we would say is the common cold or mild respiratory illness that previous known community coronaviruses caused. We do know about SARS in 2003 and MERS more recently. Fortunately, SARS was self-limited and really just essentially left us. It ended without a real clear explanation. But this current coronavirus is unlikely to leave us in the same way. The main way in which this coronavirus spreads is by air droplets from person to person. And while there are other means of ways in which the virus spreads, the main risk factor remains close contact, so being within 3 to 6 feet of an infected individual for more than 10 minutes, and then through air droplets, the virus can be inhaled. Additionally, the droplets containing virus can land on environmental surfaces, which can be touched. And then if the hands are brought to one's face and then inhaled, that is another way in which the virus can be transmitted. So this was a very early and simple explanation of how the virus was transmitted. And while it remains that this is the most common way, there's also the recognition that this virus is unique and probably is able to remain in the air for longer than was initially thought, and also has the ability to travel within droplet nuclei, which can spread further than just the 6 feet. And that probably also contributes to the very widespread contagion that has occurred within our communities. That, coupled with the fact that it is a virus without anybody having pre-existing immunity to. So I did mention that it predominantly is within air droplets, but we do know that it can be on environmental surfaces. And this was published in JAMA last month, showing in patients' rooms that were infected, the various environmental surfaces where the virus was found. And this really speaks to the main importance of washing hands, not bringing one's hands to the face, and cleaning environmental surfaces often. I'll get into a little bit more of the signs and symptoms, but the incubation period generally is from 2 to 14 days after exposure, with cough, fever, and shortness of breath, the main symptoms that individuals experience. In terms of what we are recommending to our communities to limit the spread of virus, you can see here the main points, including cleaning hands often with soap and water, avoiding close contact with individuals who are ill, those individuals who are ill should remain at home and really essentially quarantined. When people do have cough, that they cough or sneeze into clean tissues or into their elbow and not their hand. We're recommending wearing a mask if you're sick or taking care of others, and to clean and disinfect frequently used surfaces. I'll go back to number 5 for a second and say that, as many of you know, in a large number of communities in the US at this point, there really is a executive order or mandate that everybody be wearing a mask, in addition to the social distancing that is in place. That on top of that, if people are going to be out for whatever reason in the communities, the most common that we're experiencing in communities that really are practicing social distancing is for example, going to the supermarket, and a mask mandate has really been in effect. And of course, the reason for the mask is not because we believe that it can effectively protect the individual wearing the mask, but with the recognition that the mask can contain the virus in individuals who sneeze and cough, and can limit the spread of the virus. A mask mandate has been in effect within our health system since the very beginning of the epidemic, in an effort to curb nosocomial spread, which, despite the mask mandate, has been a challenge. And unfortunately, we have, despite best efforts, had several nosocomial diagnoses within our health system. So I'll speak about just some numbers to throw out. So as you have heard, 80% of individuals who will become infected with COVID-19 will be able to remain at home and recover on their own. A certain percentage of individuals will be entirely asymptomatic and will never know that they were infected, and will only learn subsequently once we start to do serologic testing. 20% do require hospitalization. 5% will require intensive care unit support and mechanical ventilation. Mortality rate has been estimated at between 1% and 2%, though if you look at different regions around the world, it is significantly higher than that. And I'll point to the experience in Italy, but as you have heard, part of the higher numbers may also relate to the fact that we are not capturing everybody who has been infected. So if you just look at the number of individuals who have been diagnosed, confirmed by testing, it probably ranges anywhere between around 5 to 8%, and even higher in some regions of the world, depending upon different factors in those communities. 80% of people who have diagnosed with COVID-19 do report having a prolonged exposure to a known case. And that really means within 6 feet for more than 10 minutes, but 20% have had only minimal exposure. And that really speaks to the fact that there are asymptomatic individuals that can infect others. In terms of where in the body the virus is found, this was an early report showing that from throat swabs and nasal swabs, the nose was an area where the highest amount of virus was present. Virus can appear very early, and does appear very early at the time of symptoms, and then gradually diminishes, but individuals can have a positive nasopharyngeal swab for several weeks after, and we have experienced that in our clinical practices over the last month and a half. The protective equipment recommendations that we are using in our health system are the use of face shields and goggles, a N95 respirator, gloves, and gowns. We currently have a mask mandate for surgical masks for anywhere in our health system, and we will be moving shortly to all staff using N95 respirators, and that will be a big change. And the reason for that is the recognition that it is probably more than simply droplet spread, and the recognition that despite our mask mandate, we have had nosocomial cases. This was published in the New England Journal and is a summary from the experience in China. And I will say that we have experienced similar characteristics in our own health system, where the median age is roughly 47. It is a disease in the hospital, predominantly of men. Again, 5% admitted to the intensive care unit, with 2.3% undergoing mechanical ventilation. The most common symptoms are fever, shortness of breath, a dry cough. A third of patients have sputum, but it is not the most common respiratory symptom. Non-specific symptoms such as myalgias and GI symptoms, including diarrhea, make up less than 5 to 7% of what we see. Lymphocytopenia with a normal white blood cell count is quite common, and the most common radiographic findings are seeing bilateral ground glass opacities if a CAT scan of the chest is performed, and I'll show that in just a moment. We all have been challenged with testing and confirmation, but I will tell you that we have moved also toward classifying patients as being at a very high likelihood of having COVID infection, despite the testing results or the availability of testing based upon these clinical criteria. Having a fever, a cough that typically is dry and associated with dyspnea, having bilateral ground glass opacities without effusions, usually peripheral, no other reason to expect these opacities, such as pulmonary edema, lymphopenia, and the absence of another diagnosis to explain the syndrome. If these strict clinical criteria are present, then regardless of the testing results, we believe that those patients have COVID-19, and we often cohort them from an infectious disease perspective and infection control perspective based upon that. This is a screenshot of a very common CAT scan finding, and we have seen a lot of this. At this point in the pandemic, we're trying not to order a lot of CAT scans and really limiting ourselves to chest x-rays, but for those individuals who have CAT scans, this is what we are seeing. The common reason now that we're doing CAT scans is because many of these individuals have courses that are complicated by pulmonary emboli, and we're ordering CAT scans to exclude pulmonary emboli in a selected number of patients, and we do CT angiograms, and this is an example of the peripheral infiltrates that we are seeing in our patients that have lung parenchymal disease. No testing is perfect, and so there is a false negative rate associated with the nasopharyngeal swabs. So for those patients that are at a high clinical suspicion, we have developed an algorithm that has been successful, and we are selectively repeating testing in individuals that meet high clinical likelihood criteria. So we don't always remove isolation precautions based upon one test result. We would remove isolation precautions if the patient is clinically at low likelihood. For those that are at high likelihood, we repeat the test immediately. In terms of therapies that are available, I'll get into this in just a moment, but remdesivir is an antiviral agent which seems to have promise, and we don't yet have full results, but we do have preliminary studies, one of which was published in the New England Journal of Medicine a little bit over 1 week ago, and there has been some leaked promising data from the University of Chicago that many of us have heard about in the last few days. There will be an analysis of the data from 2 clinical trials, hopefully available over the next several weeks, and we'll be able to learn about the safety and efficacy of that antiviral medication. There are several other agents that are being used. I'll just mention a few. hydroxychloroquine and chloroquine, based upon the potential to inhibit viral entry, has been widely used. It is not confirmed that this is successful, but it is currently widely used in the population. I did mention the remdesivir, and the other agents that I'll mention briefly are tocilizumab and sarilumab. These are IL-6 receptor blockers. The reason that these have been used is that in addition to the direct viral effects that the virus has on the lungs, there's also, in some patients, though not all, a very brisk inflammatory response that occurs. And for those individuals, it is felt, though not proven yet, that IL-6 inhibitors have an effect. There are clinical trials that we are participating in currently. We do not yet know the results of that. This is the clinical algorithm that we currently are using at our center. Patients that come in who enter with either hypoxia or with pneumonia on their chest imaging, they are first assessed to be part of a clinical trial, and they are given supplemental oxygen, but only to keep their oxygen levels between 92 to 96%. We're trying not to overdo it, so to speak, with the oxygen, and that's being driven by information and recommendations from the critical care societies. Patients will get hydroxychloroquine. We have to monitor QT intervals, and I know other speakers will talk about that. We have clinical trials for remdesivir. We have other clinical trials in place now, including the use of convalescent plasma for those individuals who have significant hypoxia and significant systemic inflammation based upon ferritin levels, C-reactive protein, or D-dimers. We consider the use of sarilumab or tocilizumab. We are really urging against the use of corticosteroids. The Infectious Disease Society of America argues not to use steroids because of concern for prolonged viral presence and because of the lack of known benefit and the risk of secondary infection. It is used in patients that are developing ARDS, and IDSA actually recommends that it only be used in the setting of a clinical trial. In the early part of the epidemic, the testing that was done, we were seeing only about 38% of our nasopharyngeal samples being positive. As the disease in our community prevalence increased, we were seeing much higher rates of positivity with the nasopharyngeal swabs. And here you can see March 22nd, it hit 50%. I'll tell you that this is an earlier slide, and ultimately we were at 70%. So 70% of individuals that were coming in to our emergency rooms with a nasopharyngeal swab with symptoms compatible with COVID were positive. In terms of when you can take patients off of isolation, currently we are adhering to guidelines where if patients have been afebrile for 72 hours, they have had 7 days since the onset of their illness, and they are generally improving, at that point, we will consider discontinuation of isolation precautions. For our employees, the recommendation initially was exposed individuals had to be out on quarantine for 14 days. It quickly became evident that this was not going to be sustainable. So it was really transitioned to all individuals need to wear masks and to monitor their symptoms. And it was a symptom-based quarantine where any individual during that point, if they became ill, then they had to take themselves out and be quarantined. We've talked a lot about flattening the curve, and this is going to be a continuous focus. The question remains as to when things can return to even slightly more normal. And I know that there is tremendous amount of discussion both in the medical circles as well as in political circles, and that will no doubt continue over the next several days and weeks. This is just really to show that while the disease has spread to every state within the US, that really the epicenter is in the New York metropolitan area where our health system is, and we really are the epicenter of the epicenter. Our health system has had to make several adjustments because the capacity needed to be expanded significantly. These are tents that have gone up in the parking lot area within our health system. And this is what these tents appear like on the inside. We've also had to take our auditorium, remove all of the chairs, and this currently is a medical unit and can accommodate 30 to 40 patients. So our entire health system has had to be expanded in ways that we never would have dreamed of before. We've also had to take physicians that would normally be doing other things, whether they be orthopedic specialists, dermatologists, OBGYN doctors, and move them in to become what I have termed COVIDists, where they are taking care of units of COVID patients to backfill the role of hospital doctors who have been moved up to provide critical care. And that has really been the theme within our health systems, as well as other large health systems taking care of many patients with COVID. Currently, our two largest hospitals within our health system have roughly 600 patients within each of the two hospitals, and that makes up about 80% plus of the total number of patients that are admitted. Serologic testing should be upon us in the next few days or weeks, but it is not clear how this will affect things. It will identify a portion, though not all, individuals who have been infected. And the other thing is that while we hope that it identifies individuals who have immunity, it is not proven that it does identify individuals who have immunity. But the hope is that it can be used to get people back to the workplace. Some of the challenges include increased need for clinical space and bed capacity, challenges related to personal protective equipment, challenges related to deployment in medical and nursing staff, challenges related to ventilators, intubation scopes, oxygen support. These are all things which our health system has had to grapple with, and I believe has done so very well. We're finally starting to see a decrease in numbers of patients within our health system that are hospitalized, and there's just in the last several days a gradual falling of the curve that you see, but at the same time there's a gradual creep upward of the patients that we have, those that are in the ICU and that are on the ventilators. Those individuals that are intubated remain on ventilators for a very prolonged period of time. This is my final slide, and I'll just say that the length of the outbreak remains unclear. Certainly, vaccine development will be the main game changer, and while it is not expected until 2021, there does remain hope that this is something that in these unique times and with reduced regulations and increased collaboration between the private and the public worlds, that a vaccine could be developed earlier. And what's important to know is the concept of herd immunity to really significantly curb the spread of this virus would require at least 65% of individuals in the community being either infected or vaccinated. So until we get to that point, it will be very hard to see full control of this virus. And I will stop there. Thank you.
Useful presentation for all of us. You have touched upon the various problems one has in the processes of setting up the treatment and the challenging demands on your auditorium and how your parking lots have been changed. But it is good to see you ending on a positive note that the numbers are now tending to get low in New York, and a vaccine that you have discussed. We will take up questions on some of the very interesting issues that you have touched upon. We will have the 3 presentations first, and I would request you to stay back so that when we have questions, we can all discuss the various aspects. We will now go on to the second talk, and this will be by Professor David Margery. He's a medical director of the Mechanical Circulatory Program in the prestigious North Shore University Hospital, Manhasset in New York. He works in the Advanced Heart Failure Division of the Department of Cardiology. He has extensive experience in LV assist devices, but I think we will leave that for some other good day. He's a graduate from the prestigious Johns Hopkins School of Medicine in 2004, and he subsequently had his training in cardiology and in advanced heart failure at the University of California in San Francisco. So we will listen to the cardiovascular complications and their management from David Margery. Professor Margery, please.
Thank you very much. I'm going to share my slides here. Thank you much for having me. I'm going to talk about really the cardiovascular complications, which are more and more being apparent to be an issue related to patients who are ill with COVID-19 and who are hospitalized. I want to talk about really the impact of cardiovascular comorbidities on outcomes with patients with COVID-19 and focus on risk stratifying measures for your patients who are admitted and how we can think about who's at more risk for having adverse complications. I also want to talk about our current understanding of myocarditis and the mechanisms of injury that might underlie inflammation of the heart during COVID-19 illness. And I'll talk about arrhythmias and monitoring associated with arrhythmias, as well as strategies for thromboprophylaxis. Now, as Dr. Hirschberg pointed out, COVID-19 really impacts a wide variety of organs, inflammatory systems throughout the body, which leads to upregulation of a variety of cytokines, as well as acute lung injury, all of which very likely could impact myocardial injury. The myocardial injury can manifest in a variety of ways, whether it be right heart failure due to ARDS, acute myocardial dysfunction, as well as just injury to the myocardium with elevation in troponin and BNP. We see this manifest in a variety of ways, and quite frankly, we still don't exactly understand the epidemiology behind this or the frequency of acute myocardial injury. First, let's talk about the baseline comorbidities that appear to be associated with poor survival. One thing that is very clear is that patients who have more baseline comorbidities do worse with this illness. This is one series out of China looking at 1,590 patients who were admitted with COVID-19, and they looked at 4 comorbidities: COPD, diabetes, hypertension, and malignant tumors. These patients had an increased hazard ratio of admission to the ICU, intubation, and death. Notably with COPD and malignant tumor, but the most common patients or the most common comorbidities that were found were diabetes and hypertension. And importantly, they showed that it wasn't just if you had a comorbidity, but the number of comorbidities that you had really impacted how poorly you did. This is shown quite clearly in the slide here. Once again, the same endpoint: ICU admission, intubation, and death, showing that as you increase the number of comorbidities that you had, you did poorly. Now, it's important to recognize that even the patients who didn't have comorbidities also had elevated risk of poor outcomes. But undoubtedly, the more comorbidities you have, the worse you do. Now, in New York, as Dr. Hirschberg pointed out, unfortunately, we're seeing thousands of cases. And New York has a central database where they evaluate patients. This was updated on Wednesday. So out of 10,800 deaths, 89% of those people who died had at least one comorbid condition. The most common conditions were hypertension, diabetes, and hyperlipidemia. And you can see here, this is stratified by age range. The patients who were over ages of 60 up above 80 years of age more frequently had hypertension and diabetes. So it's really notable that 64% of the patients who died had hypertension. Going into this epidemic blindly, one might presume that patients with chronic respiratory illness, COPD, and asthma might fare worse, but that's really not what we're seeing. We're seeing that patients with more metabolic syndrome, cardiovascular disease, those are the ones who are really suffering, and the reasons for this are still not completely clear. So up front, recognizing that patients with comorbidities perhaps can help you identify patients who are at higher risk for further illness. So why is this? Well, one thing that we're seeing is that myocardial injury is common and it's deadly. There are a number of hematologic, biochemical, and inflammatory markers that we look at in patients who are admitted with COVID-19. There are a few that many of us tend to focus on depending on what we're really looking at, but we definitely follow markers of cardiac injury with creatine kinase, CKMB, and cardiac troponin. But we also look at LDH, markers of coagulation, and the inflammatory biomarkers such as erythrocyte sedimentation rate, CRP, ferritin, and procalcitonin. So what do we know about elevations in troponin? Well, you can see here in this slide, and this was a series of just shy of 200 patients out of China, showing that elevations in troponin and their interaction with baseline cardiovascular disease impact survival in patients. Notably, the lowest curve there, patients without cardiovascular disease and a normal troponin, they fared the best in patients who were hospitalized, albeit still with a seat mortality of 7.6%. Patients who had cardiovascular disease but did not manifest with an elevated troponin fared worse, but the patients who truly fared the worst were those who had cardiovascular disease and elevated troponin with an exceedingly high mortality of approximately 70%. The authors further looked at patients who died as compared to patients who were so-called cured or discharged from the hospital. And it was very notable that patients who died during the course of the admission had elevation in troponins that further worsened as they approached death. In contrast, patients who survived the hospitalization did not seem to have dynamic changes in their troponin over the course of the hospitalization. Now, this was slightly different when looking at NT-proBNP, where patients who were cured did have dynamic changes in proBNP. So what does this potentially signify? Well, patients who are getting sicker, who are intubated, who are hypoxic, who are developing cardiovascular collapse, who are hypotensive, requiring vasopressors, those patients are probably developing myocardial injury as a secondary phenomenon from the critical state of their illness. And we see this as their increased troponin evolves. With BNP, it's very possible that the BNP elevations are related to the increased RV stretch or right ventricular stretch that occurs in patients who develop ARDS, but perhaps don't develop as severe illness as the patients who go on to develop increased troponin. Of course, these are still hypotheses that need to be tested, and we at Northwell, unfortunately, since we do have so many patients, are looking into this, and hopefully we'll have more clarifying data out soon. This is another example. This is looking at 14 patients who died in China and looking at the time course and changes in troponin and NT-proBNP, and I think this reinforces that prior statement. So we see that patients, after they are admitted, in this slide, 12 days before death, have low levels of CKMB, troponin, NT-proBNP. But as they become ill and as they approach death, we have increases in those biomarkers, once again, in my mind, suggesting that they are simply developing cardiovascular derangement, which is leading to an increase in leakage of these cardiac biomarkers and increased stretch, probably in particular, once again, the right ventricle, leading to increases in NT-proBNP. So is myocarditis a contributing factor? This still remains a question. I'll tell you, when I first recognized that we were going to have such an onslaught of patients as an advanced heart failure doctor, I thought we were going to be deluged with consults related to myocarditis, but truthfully, we haven't been. Early on, we had one patient that we think suffered from acute myocarditis. We got involved, thought about placing that patient on ECMO, but he died within 12 hours of our notification. Nonetheless, there are a number of case reports, perhaps about 6 to my last count, looking at patients who developed some form of myocarditis. The second entry here was a patient that was treated with glucocorticoids and human immunoglobulin. And that patient was reported to have recovered his acute LV systolic dysfunction after treatment. But the utility of these therapies is still unknown, and I think I would be very cautious up front for the reasons that Dr. Hirschworth mentioned, to give lots of steroids, but truthfully, we still don't quite know what to do there. But what's actually going on here? Well, we know that the virus enters the cells via the ACE-converting enzyme ligand receptor on the cell surfaces, and that ACE receptor is located on a variety of cell types, and certainly is present on cardiomyocytes. So certainly there is a potential that the virus could enter directly into the myocytes. And importantly, the related beta coronavirus SARS-CoV-1 that was responsible for the initial SARS epidemic has been shown to enter cardiomyocytes. Coming out of one case report in Lombardy, Italy, a patient, relatively young patient, was admitted with shortness of breath and was found to be SARS-CoV-2 positive. They were also found to have, or he was also found to have evidence of acute LV systolic dysfunction. He declined, required inotropes, a balloon pump was placed, continued to decline, and was placed on VA ECMO. And at that time, they did an endomyocardial biopsy. This is looking at the myocardial tissue. And I think what's really notable here is that in patients who have fulminant myocarditis or lymphocytic myocarditis, we typically see a lot of lymphocytes, and those would be the lots and lots of blue cells. And here we don't see that. We don't see a lot of lymphocytic infiltration in these cells. What we do see is CD68 positive staining of macrophages in the interstitium of the cardiac tissue. And then on electron microscopy, these red arrows are pointing out the virus particles. You can see them, the very typical round-shaped virus with the studded receptors on it. These were found in the interstitial cells of the myocardium, but they did not identify the virus within the myocytes themselves. So at least in this example, and mind you, this is just one example, so the jury is still out, there was not evidence of acute myocarditis per se, or at least not what we would expect to typically lead to cardiac inflammation leading to acute ventricular systolic dysfunction. So the mechanism of acute systolic dysfunction or LV systolic dysfunction is still uncertain, and I think we need a little bit more information. I will say that I spoke earlier this week with our cardiac pathologists at Northwell, and at the time they had done 6 autopsies of patients who had died with COVID-19 but had not identified evidence of myocarditis in those patients, but it's possible that we just haven't identified them yet. I'll say in our intensive care unit, we are not doing a lot of dedicated echocardiograms, largely for the concern of exposing our echocardiographer technicians to COVID, but we are doing point-of-care ultrasound. And while there have been some cases of acute LV systolic dysfunction, that does not appear to be the prominent mechanism. So what about arrhythmic events? This is obviously something that everybody's very concerned with. There have been reports of increased incidences, or rather high incidences of arrhythmias. This is looking at several papers from China, pointing out in the second one there, 17% of patients with arrhythmias. In the last paper by Guo et al., 5.9% of patients having VT or VF. And we've certainly seen our fair share of arrhythmias. Last week, I had 3 patients who did develop ventricular tachycardia, some of whom spontaneously remissed, others who had to be defibrillated. But it's complicated, and it's largely complicated because some of the therapies that are widely being used also predispose patients to arrhythmias. So in particular, a lot of patients are being treated with hydroxychloroquine and chloroquine at our institution. If they meet criteria for progressive disease, they do get treated with hydroxychloroquine, as Dr. Hirschwerk pointed out. Now, this was a study that preliminary data was just released from Brazil on RXIV. And basically, they had to stop this trial. It was looking at low-dose chloroquine versus high-dose chloroquine in Brazil. Small number of patients, but in the high-dose chloroquine arm, there was 7.1% of patients had ventricular tachycardia. That was 2 out of 28. There was QTc prolongation of greater than 500 milliseconds, and upwards of 25% of the patients in the high-dose arm and 11% of patients in the low-dosage arm. Now, it's important to note that these patients were also being treated with azithromycin in this study, which, of course, is also known to be a QT prolonging medication. But I think when you get the combination of patients who at baseline have a higher risk of cardiovascular disease, and then you're adding on therapies that can prolong QT interval, well, certainly there's going to be an increased risk of arrhythmias, in particular ventricular arrhythmias. So in addition to perhaps the increased risk of arrhythmias that could be due to the acute inflammation related to the disease itself, we are using medicines that can prolong this risk. So at Northwell, we have a strategy. Our electrophysiologists have been very involved in creating mechanisms by which we can screen our patients to minimize risk of arrhythmias, and in those patients who have an increased risk of arrhythmias, making sure that we are monitoring those patients closely. So first and foremost, we make sure that we optimize potassium and magnesium supplementation in those patients, and we follow it very closely during the hospitalization. For patients who have a QTc interval of less than 500 milliseconds, we will start hydroxychloroquine in those patients who are eligible for those therapies, and we don't follow them more closely unless there's another indication to do so. But in patients who have a QTc greater than 500 milliseconds, we need to really think about the risk-benefit of those patients receiving those therapies. And mind you, we still don't know that these therapies actually impact a positive course on patients. The jury is still out on that, and hopefully we'll have clarification of that soon. But it's important in those patients who do have a prolonged QTc interval to be very careful about using these therapies and then monitoring them closely. So how do we treat patients with COVID-19? Quite frankly, this is not a cardiology-specific therapy apart from the arrhythmic precautions. I took this from the Surviving Sepsis Campaign recommendations, and most of the therapies are really related to good pulmonary care and good critical care in those patients who are admitted. Of course, this has been found to be very complicated and very difficult to manage. Patients who are intubated are extremely difficult to get extubated. They tend to be very PEEP responsive. But they also require an awful lot of sedation. So once they are intubated, it can be very difficult to extubate. But this cardiology-specific care, in my mind, is really related to treating around the issues that can lead them to having worse cardiovascular function, and is really an entirely different lecture. The last thing I want to talk about is prophylaxis of thromboembolism. As Dr. Hirschwerk pointed out, patients who develop COVID-19 are at augmented risk for thromboembolism, both microthrombi that has been observed in the pulmonary vasculature, as well as frank acute pulmonary embolism, which we have also observed. So at Northwell, we have a paradigm for treating people with enoxaparin that is weight-based and renally based, or unfractionated subcutaneous heparin in patients who have a low creatinine clearance less than 15 milliliters per minute. In patients who are in the intensive care unit, we also add intermatic pneumatic compression devices. But while we were giving them this therapy, we're also mindful of their bleeding risk and use the risk scores to help determine that bleeding risk. So in summary, myocardial injury is likely a secondary phenomenon, but the data are still not completely in on this. You need to monitor your patients with comorbidities closely. They're at very high risk for decompensation, especially when hospitalized. You can use troponin and proBNP to help risk stratify patients. If it's increasing, those patients may need more intensive monitoring. And reassuringly, patients with low TNT and proBNP may be in a lower risk category. It's very important to monitor for arrhythmias and have caution with QTc prolonging drugs, especially in combination with other drugs that prolong the QTc interval. And be mindful of prophylaxis and monitoring for thrombotic and microthrombotic events. Thank you very much.
Thank you, Dr. David Margery, for this beautiful presentation, taking us through the profile of patients with with the profile of cardiac manifestations, and I'm sure there will be a lot of questions to this very interesting talk, cardiac manifestations. But before that, we will have a presentation by Professor Prem Soman, who works in the University of Pittsburgh Medical Center. He's an associate professor of medicine. He's director of nuclear cardiology. He had his initial medical training in India at the PGI Chandigarh. Then he went on to UK, worked in Northwick Park Hospital, got his PhD, went to US, then did his fellowship from the Tufts Medical Center in Boston. And he's been a president of the American Society of Nuclear Cardiology. And he's going to talk to us on cardiovascular care during the COVID-19 pandemic. And then we will have the discussions. Over to Dr. Prem Soman, please.
Thanks very much. Hello, everybody. So in the next few minutes, and I'll try to be quick because I can see that we are running over time. I'm going to talk a little bit about how this pandemic has profoundly affected the way that we assess and treat general cardiology patients. This has happened for two reasons. One, because of the social restrictions in place, patients sometimes are not able to access medical care. And when they are able, even when they are able, they're also apprehensive to come to the hospital to seek medical care. On the other hand, hospitals have had to tone down their operations to a significant degree to comply with state and governmental regulations. I work at the University of Pittsburgh. We are a large integrated delivery system with about 40 hospitals in Western Pennsylvania and in the immediately surrounding areas of some of our neighboring states. Luckily, we have not seen nearly the number or intensity of cases that the two previous speakers have encountered in New York. But even then, our outpatient and inpatient testing and procedural activities have reduced by 70 to 80%. So in the next couple of minutes, I'm going to talk to you about our experience with this and the principles that we have used to comply with the governmental and infectious diseases recommendations for disease containment. So I'm assuming that you can actually see my slides. This slide talks about the general principles that are recommended in terms of identifying what sorts of patients we should continue to see and treat at this point of time in the pandemic. And of course, the highest priority is given to preventing transmission to medical staff and other patients and revolve around social distancing and containment of the disease. I think we've all begun to preferentially use conservative treatment, particularly in the management of non-acute coronary syndromes. And of course, most of us have relied very heavily on our ID departments and the ID guidelines to develop these principles. Now, at the very outset, I will also mention that there is an other side to this story, and that is that some sick patients, not COVID patients, but general cardiology patients, are not able to seek care. And there are emerging reports, for example, of delayed presentations of ST elevation, myocardial infarction, and stroke appearing during this pandemic. So while we want to comply with the social distancing and containment principles very effectively and very carefully, we also need to be vigilant to make sure that patients who need care, general cardiology care, are not being overlooked or going unrecognized. Now, this slide, I got this from a colleague in Italy, talks about the different phases of this disease.
Thank you.
As you can see, the initial phase of the viral response phase can be largely asymptomatic and may apply to up to 80% of patients. And some patients go on to the second stage or the pulmonary phase, and a few patients go on to this third stage of hyperimmunity. But in terms of looking at hospital and practice policies, it's this first stage that we are really worried about, and that is the asymptomatic transmitter of disease. As David already mentioned, from among the large number of infected patients, it's actually only a minority, 12 to 19% of patients who require hospitalization, and a small minority that require critical care. So most of the disease spread is probably from stage 1, and that is the majority of patients. This is a table that shows the level of protective equipment and protection policies that are recommended. Of course, standard protective equipment is recommended for everybody. And in the context of COVID, there is the special droplet precautions and the airborne precautions. The difference between the two being for special droplet precautions, a surgical mask is all that is recommended at this time. If N95s are available, they should be used. But in terms of preservation of PPEs, a surgical mask might suffice for most patients for special droplet precautions. And of course, when airborne precautions are required, then one has to go to the whole gamut of protective equipment. There are a number of guidelines that have appeared, and here are some examples of guidelines. Every society has issued its own guideline. The American Society of Echocardiography, for example, has some very nice guidelines for the identification of patients who should continue to have echoes, guidelines to perform transesophageal echocardiography, which is one of the highest risk procedures. And the American Society of Nuclear Cardiology offers a scheme to prioritize patients based on the indication that might be applied to patients. Now, in the outpatient setting, the Medicare, the United States Medicare also offers a scheme for triaging patients into tiers of importance, and based on this, whether to continue to provide routine primary or specialty care. And again, these are just guideline documents, and these have to be applied to each individual patient depending on the unique circumstances of that patient. Of course, the basic principles are, even in the outpatients, that all patients are screened with a questionnaire. And in fact, at UPMC now, everybody, patient, visitor, staff, everybody who enters the hospital has their temperature taken and is mandated to wear a mask while on the hospital premises. In fact, the city of Pittsburgh now mandates the wearing of a mask for all people when they venture outside. Now, at UPMC, in our 40 or so hospitals, about 90% of our visits are now virtual televisits. And across the United States, Medicare and all the private insurers have been extremely cooperative in allowing the transformation of face-to-face visits into virtual visits and providing the ability to bill for these patients. Now, in the inpatient area, we have developed this system. Everybody's screened for COVID, and if they are not suspected of having COVID, then they are triaged to a standard care. And this is, depending on the reason for admission, this might be on a general cardiology service or a heart failure service, electrophysiology, or a service of intensivists. Now, for patients who are being suspected, who are suspected of having COVID and are being tested, we now have a dedicated attending and fellow team who will take care of these patients while their test results are being awaited on a dedicated floor. Now, if they test negative, then they go back to routine care, and if they test positive, then they go back to to a dedicated COVID unit that is managed by a specialist team, a multidisciplinary team of physicians, paramedical staff, nurses, and trainees. And this is being followed very, very stringently across our hospital systems. In terms of non-invasive testing, the general principles are that we perform testing only if the results are required to implement essential management interventions in the near term. So some examples of this situation might be patients who have escalating anginal symptoms that require stress testing or coronary angiography. TEE, for example, for mechanical complications of endocarditis that may influence decisions to perform or not perform surgery. The second large group of indications is where the lack of testing might adversely impact other aspects of patient care. For example, many patients will need a stress test to be discharged from hospital. And we do test these patients following all the recommendations. Another situation is preoperative evaluation for surgery. If the surgery is semi-urgent and not having the pre-op evaluation will impact on whether the surgery will be performed. And we encounter this mostly in the transplant arena, where transplant surgeries in ill patients are not generally being deferred. General recommendations for cardiac testing is that, of course, we screen all patients in all our laboratories. We use the minimum number of people who are required to perform a test. Usually, for example, in our nuclear lab, we have a technologist, a nurse, and one physician who performs all the tests or is exposed to every patient who's having a test. The recommendation is not to perform the usual comprehensive exams, but focus our exams to the question being asked, for example, echocardiography, which might require some planning ahead of time, and to make very thoughtful choices about protocols. For example, in the nuclear arena, to do stress-first imaging for patients with suspected CAD, so that if the stress is normal, then they don't have to go on and have a rest study. I listed here some specific recommendations for individual test modalities. We're all completely cognizant of the fact now that TEE is among the highest risk procedures, and this is transesophageal echocardiography. At UPMC, we mandate an N95 mask and face shield for all patients who are having TEEs, not just suspected patients. These tests are now performed preferentially at the patient's bedside. We don't bring the patient to the echo lab. Fellows are currently not allowed to assist TEEs, and these are done by an attending consultant physician with one nurse assisting. And we're very careful about who we test. Some indications, such as ruling out atrial appendage for patients prior to atrial appendage clot prior to DC cardioversion, is now done by CT rather than by TEE. For transthoracic echoes, the recommendation is that we do a quick focused exam to limit the exposure of the technologist, the sonographer, to the patient, and, for example, perform all measurements offline rather than while the study is being performed. In the nuclear lab, we preferentially use vasodilator stress testing even when the patient can exercise, because that limits exposure to that is the modality with the least exposure to the healthcare staff. And in the cath and EP arena, whenever possible, it's recommended that a dedicated room be used for suspected or proven COVID-19 patients, if at all possible, and use negative pressure rooms when available. Another point I wanted to make is DC cardioversion is generally considered a higher risk procedure because of the requirement for high flow oxygen during the procedure and the risk of aerosolization. There are a number of CPR guidelines. In my experience, many of these are difficult to implement, but this is one of the situations where a great consideration has to be given to exposing the medical personnel. David spoke about troponin elevation. I just wanted to talk a little bit about identifying patients with an ST elevation MI, because this has become quite a challenge during this pandemic. Now, this slide shows the number of potential mechanisms by which patients with COVID can have a troponin elevation. And our challenge when we are facing this pandemic is to identify patients with a type 1 myocardial infarction and take them and only them in a timely manner to the cath lab, so that we are not exposing patients in the cath lab to situations where there is not a high risk of this being a true type 1 myocardial infarction. This is a time more than any other, perhaps, to remember that the definition of a myocardial infarction as opposed to myocardial injury was very clearly delineated recently by the 4th Universal Definition of MI Working Group. And while an elevated troponin establishes the diagnosis of myocardial injury, the diagnosis of myocardial infarction requires, in addition to the troponin elevation, very definite evidence of myocardial ischemia, either in the form of new symptoms, new ECG changes, or a new wall motion or perfusion abnormality in the rare situation that an acute chest pain study is performed, which we sometimes do. So we have to be careful and very stringent in the criteria for myocardial infarction before we take these patients to the cath lab. This is our protocol. We are not routinely using thrombolysis as the preferential treatment for patients with ST elevation MI, but in patients with confirmed or high probability of a COVID infection, if they are stable, one might consider using thrombolysis as the primary approach. Taking care to monitor these patients for complete resolution of ST segment elevation very quickly, and if that doesn't happen, take them back to the cath lab for a PCI. And even in patients who've had complete resolution of the ST segments with thrombolysis, in most of them, we perform angiography in the next 24 hours to make sure that there is no residual stenosis. And finally, I think it's also really important to remember that when a patient with COVID is tested or treated, either in the echo lab, in the nuclear lab, or in the cath or EP labs, very careful decontamination of the room with strict adherence to recommendations after these procedures is really very important. Now, there are lots of recommendations available online to help guide the process of decontamination, but it's very involved and it takes a lot of time. That might or will definitely interfere with the throughput of the lab, but it's really important to adhere to this. So I will stop here and hand over to Dr. Wander again.
Some very useful comments by all the three speakers who have first-hand experience in managing these patients. There are a lot of questions flowing, but I think we will start with Professor David Hirschberg. There is a question from a lot of physicians. They feel that the Indian Council of Medical Research has suggested that healthcare professionals who are looking at COVID patients can start prophylactic hydroxychloroquine at the dosage of 400 milligrams weekly. What percentage of American doctors are using this prophylaxis? They would like to know from you.
I don't know the number, and it's not something that's being recommended within our health system, so I don't really have any data for it.
There are no guidelines in the US system for prophylactic use in high-risk individuals for hydroxychloroquine.
Correct. There are clinical studies that I'm aware of that are happening, but it's not something that we are advocating. In fact, we're advocating against its use, and there was a lot of buy-up of this drug early in the epidemic, and our pharmacy had to take steps to stop that.
Okay. Second, there are a couple of questions regarding aerosolization. There is a lot of fear. So what is your CPR protocol? What is your protocol for using nebulization, BiPAPs? Have you altered your protocols in such patients at this time for COVID and non-COVID patients?
Yes, we're not using BiPAP, we're not using high flow, and we're not using nebulization.
Okay. So that clarifies some important changes that we need to bring about in our practices in these COVID times. A couple of Indian physicians want to know, actually, there have been two issues which have been talked of. One issue of delaying ventilation as far as possible. What are your comments on this?
So I think we don't yet know whether the strategy of early intubation or later intubation is better, but we do have some data, and we're in the midst of preparing an abstract. Actually, we prepared a manuscript to look at this with some data suggesting that early intubation may actually be preferred, but it is currently still in review.
There is a question from Dr. Smith Srivastava from Raipur. He wants to know what would be a good investment at this time, oxygen concentrators or ventilators? We are all working in resource-deprived situations.
Right.
So what would be your thought?
Well, I mean, I think both of those are important, and it really has to be based upon a needs assessment. Within the hospitals themselves, it's certainly necessary to have ventilators. On the other hand, for patients, that many of the patients remain in the hospital simply because they can't leave the hospital without oxygen, and we're actually challenged. We are challenged right now by getting a sufficient supply of concentrators so that many of our patients can be discharged out of the hospital. But both of those factors are important with respect to how we're managing numbers of patients within the hospital. I think it's really based upon the needs assessment within each hospital.
You did talk about a discontinuation of isolation, which concerns a couple of physicians here because the protocol here is longer. You mentioned that by the third day, if they are afebrile, their isolation protocol. So can you just comment here? Our guidelines suggest a longer because the virus shedding keeps on happening, and there are some experts.
Yeah, let me try to clarify. Sorry, let me try to clarify that. In-house, for the patients in the hospital, we're not discontinuing isolation. That's just not something that's been happening. What I really meant was those patients that are discharged and sent home. The question has come up as to when, for how long do they really need to, remain quarantined from other household members? And for that situation, really, it's and when can they actually return to certain medical offices to receive outpatient or ambulatory care? And there's been different views on it, but what we are currently using is the New York State guidelines, which recommend 7 days from the onset of illness, 3 days of being afebrile without antipyretics, and an ongoing continuation of improvement clinically.
Thank you, Professor David Hirschwick, for very nicely handling some of these issues. There are a couple of questions from Professor David, Margery. One of our colleagues, Amit and Dr. Abhishek, they want some clarification on the patients of coronary artery disease, because what we saw was patients of hypertension, almost 65% of them who have bad prognosis. So they're very keen on knowing, how do patients of coronary artery disease figure, and can you just clarify on this subset of patients?
Well, there's no doubt that those patients are at much higher risk. I think the challenge is discriminating the myocardial injury that, once again, is a secondary phenomenon from the illness, as compared to those patients who may be suffering from, say, plaque rupture, which we know even in the setting of sepsis can certainly occur. So it's not hard for me to imagine that amongst the large number of patients that we see, that some of them will, in addition, suffer from acute myocardial infarction. And I think that's what Prem was talking about in terms of trying to risk stratify those patients. Do you take them to the cath lab? Do you use thrombolytics? There's been a lot of consternation over the proper way to treat those patients, trying to minimize exposure to treating physicians and minimize exposure to other people within the hospital. So it's a real challenge, especially recognizing that those patients are at a higher risk for poor outcomes. One of the things that I'm seeing in the question and answer thing is one of the ongoing questions related to ACE inhibitors and ARBs. The current recommendations are to continue ACE and ARB therapy in patients who are on them. However, if these patients are becoming hypertensive and have a reason for discontinuing the medications otherwise, then of course you're going to be discontinuing these medicines. A lot of the patients that are critically ill or coming in acute renal failure, unfortunately, our dialysis services have been taxed heavily in the hospital due to a large proportion of patients requiring dialysis and ultrafiltration. So acute renal failure may be another reason why you might have to discontinue ACE and ARB therapy. Now, ultimately, whether or not ACE and ARB therapy is going to be beneficial or harmful is unknown. I can make hypotheses in either direction, and people have done so. There are several people looking into this. There's one trial of losartan that's underway. We are going to be reviewing our series, and hopefully we'll get some data out very shortly to help guide people in this regard.
Well, that was another question which a lot of people were asking about ACE ARBs, whether to continue, although most guidelines today suggest that we should not withdraw ACE inhibitors or ARBs on patients who are already taking these drugs. But it does concern a lot of people, and there were a lot of questions. Just as I asked Professor Hirschwick about the delayed ventilation protocol, which we have been hearing about amongst physicians who are managing these patients, what are your comments on the use of fluids in these people? Because Dr. Shiba Chabra, a couple of other doctors wanted to know, in these patients with ARDS, how do you go about using fluids and inotropes, vasopressors? What is your...
Well, I mean, this is the common problem in anybody who develops ARDS. It really requires looking at the individual patients, typically speaking, dry lungs or happy lungs. And so we certainly try to keep people as euvolemic as possible. But the truth is, as patients get more critically ill, especially patients who are presenting to the hospital after having been ill for several days, perhaps delayed presentations, they might be very hypovolemic, perhaps they've had diarrhea, they may require an awful lot of volume in order to adequately resuscitate them. And then inevitably in the patients who are very ill, there can be capillary leak syndromes. They can end up becoming very volume overloaded. One has to be mindful of the potential for RV systolic failure that can be acute, either directly due to the ARDS or, once again, the potential for acute thrombotic events. So those patients might need a different approach towards inotropic support and volume management. But the principles should be, once again, those principles of critical care medicine, which is to volume resuscitate as necessary, but be mindful of not over resuscitating a person, especially in a person who potentially could have a susceptible right ventricle and developing low cardiac output as a result of right ventricular failure. These are not easy issues to get at, especially if you don't have a good mechanism for assessing right ventricular function. Of course, some patients will go on, well, in centers that are able to do so, to ECMO. At Northwell, we've placed, I think, 7 or 8 patients on VV ECMO and 2 patients on VA ECMO with variable response. But that gets at a much higher level of issue. Unfortunately, it hasn't been too terribly common.
There are a lot of colleagues, one of them is Nishant, who's just again written this question. A number of them have come. What is your protocol for use of anticoagulants? Because we've all read that microthrombi occur and D-dimers are high in these people. Prophylactic and therapeutic dosage. You didn't touch upon this, but it still concerns a lot of physicians over here.
Well, and it concerns us too. I mean, it's a constant question to ask, but at the basis of the conversation is the prophylaxis, and that's the strategy that Northwell has developed. Fortunately, we have one of the world leaders in anticoagulation at our institution who's helped us to put together the protocol regarding prophylaxis. But I think the question that comes into play is, what about in patients who have markers of elevated thrombotic risk? They're showing evidence of DIC. What do you do? Well, quite frankly, some of those questions aren't even fully answered in patients who have DIC in setting of sepsis otherwise. We've had patients who have developed acute PEs. One patient at one of our sister hospitals, LIJ, was even given thrombolytics for the suspicion of acute PE and actually improved. But it's really a challenging thing to get at. I've had a number of patients who were on Coumadin therapy at baseline who come in with INRs of 10, 11, 12 or so. And we suspect that that's, once again, a reflection of the overall inflammatory cascade, but might not be necessarily them being more at risk of bleeding or clotting, for example. So in my mind, it's still uncertain. I don't know if Dr. Hirschwerk has any comments to add to that, but I think it's a real challenge, and you need to look at the individual patient's thrombotic versus bleeding risk, is the way that I would do it.
Well, thank you, Professor David Margery, for answering these things which are bothering physicians across India. A couple of questions for you, Professor Prem Soman, and one of them I can see right away on my screen is patient having chest pain, raised troponins, ECG not showing anything. What would be your guidance to approach?
Yeah, that's a challenging one, and as I said, we are very careful now about taking patients to the cath lab only if they have the full gamut of the criteria that define an acute myocardial infarction, and that is ST elevation, unequivocal ST elevation in 2 contiguous leads, patient with chest pain, or one of the other evidences of acute myocardial ischemia in the form of wall motion abnormalities. Now, echocardiography is really very useful in these patients who don't have obvious symptoms and present with ST elevation. And ST elevation, as you know, can happen in patients with myocarditis who usually also have pericarditis, and they can have non-specific ST wave changes. So it is a challenge but we try to stick to the criteria and take patients to the cath lab only if you're convinced they're having an ST elevation.
You made a comment, Professor Prem Soman. I might tell you that Dr. Sandeep Bansal was with you in PGI, and he's just written that he's happy to see your face after 30 years.
Hi, Sandeep. Nice to connect after so many years.
And there are a couple of physicians wanting to you to elaborate a little bit further on your comment that 80% of the consultations these days in your setups are virtual consults. So
yeah, so this has been a completely new and actually one of the nicer experiences from treating these patients. So in my own practice, in my clinic, I rarely did virtual visits or telephone visits. Now that pretty much our outpatient services are shut down, except for people who require semi-urgent consultations, we now have the ability to connect with the patient using some apps that will facilitate face-to-face conversations. It's like using FaceTime, but we use an app that goes through our electronic medical record. And in our environment, documentation of encounters and billing for encounters is a big issue. And so the system has actually geared up. And now across the nation, there are billing codes that allow us to bill for various levels of both face-to-face and telephonic visits. And in fact, I think a proportion of these visits are going to continue after the COVID pandemic. And many patients can very effectively be managed, particularly return visits. It's a little more difficult to manage first-time visits without physical exam and a face-to-face visit. But if you put somebody on new therapy and you just want to make sure that they're doing okay on therapy, that's the sort of visit that can be very nicely done using these sort of encounters, virtual encounters. And many patients love it. We're a quaternary referral center, and so sometimes patients have to travel a very long way to come to see us. I also have an interest in cardiac amyloidosis, and I run our amyloid center, and I've decided that most follow-up visits for these patients who travel many miles to see us, I will do those in the future by virtual visits. So this is one aspect of our practice that I think has been permanently changed by this experience.
Well, let me, in the end, thank Professor David Hirschwig, Professor David Margery, and Professor Prem Soman for these very clear presentations on this very diverse infectious disease, which has varied modes of presentations. And I know we have all gained enormously from your experiences. It would have been very difficult for all of you three to have come out, especially at these times. And we truly appreciate your efforts to have shared some of your real life experiences of this difficult time. We, all the physicians across India, wish you all the best in the coming times, and look forward to having deliberations subsequently. I must thank the INEDSYS group for having put up this meeting together, and Professor Sanjay Satyarthi for his effort. He's a hepatologist for having put this interaction between the three of you and physicians across India. Thank you very much once again to the three speakers, and wishing you all the best, and wishing all the best to my colleagues who have spared so much of their time on this Saturday evening. Thank you, one and all.
Thanks very much.
Thank you.